me one second. So the remaining VBR requirements going on for this year. So we are asking ongoing sites, so that's any site that is not your first year in the collaborative, that each physician in the collaborative who's earning value-based reimbursement will watch the recording of this webinar by January 12th, 2024. We'll distribute it to all of you and your POs next week and would ask you to share this recording with others in the practice. And then there will just be a short survey that they complete alongside it, just to demonstrate like listening and understanding to the presentation, and we'll get that out to you shortly. And for new sites, so Dr. Plattner, this is your site only actually. Each physician within the practice must complete a brief self-reflection exercise on the quality initiatives. That's also due January 12th, 2024 too, and we'll send out reminders on who still needs to complete that as we get closer to the due date as well. And then as a reminder, the way that the value-based reimbursement year works for specialists is that the new year, and we pay these prospectively. So when the new VBR year starts on March 1st, 2024, you'll begin earning that 5% uplift on all of your Blue Cross Blue Shield PPO patients. And then throughout the VBR year, which ends February 28th, 2025, you'll be meeting the requirements listed on this slide. So the first ones you should be familiar with, they're ones that we've had each year of your participation in the collaborative. So we plan to still keep those spring regional meetings with all specialist types attending, and those are in person. So we'll have the PCP practices, the nephrology practices, and our endocrinology practices. And then we plan to move forward in the same way that we have of having a nephrology only clinical champions meetings in the fall, which is what you're attending now. And we'll do that again in next year. And then as far as for what we're asking you to complete in this next year of value-based reimbursement, we're trying to get closer to ultimately having performance measures within the collaborative. And in the meantime, are building in some process measures that are meant to indicate like the same progress on those measures without directly looking at your performance rates right now. So the things that we're asking are for you to develop a process change plan with your practice to either increase prescribing of guideline-directed therapy for patients with type 2 diabetes or increase urine albumin testing, and then just submitting the plan of what you're going to be doing differently in your practice to us at MCT2D. And then we'll ask you to kind of report out on how those process changes went at the fall nephrology clinical champion meeting. So we're asking that you submit them to us and have them planned out by March 1st. And then we'll ask you on this meeting, like, how did it go? What did you learn from doing it? Do you feel like you were able to make a change either in the guideline directed therapy or an increase in urine albumin testing? So these two are linked together, and that this one's a report out of that plan that you're implementing. And then finally, we're asking that you work with your physician organizations to choose a primary care practice to partner with within your PO, and then working together to identify an aspect of care coordination that can be improved, developing a plan for improving that, like, for example, partnering to develop an improved referral or handoff process. So again, it's going to take place throughout the course of the VBR year. We'd ask that you define a partner by April 1st. And again, we'll really work with your POs to help determine that. We'll have a plan submitted by June and then feedback in that November 2024 session, likely in the fall nephrology clinical champion meeting as well. And then finally, the last little bit of operational updates, we wanted to let you know about our newly recruited nephrology sites. So we just finished our yearly recruitment cycle, and we're having 4 new nephrology practices join the Michigan Collaborative for Type 2 Diabetes beginning next year. That's going to be Munson nephrology consultants, so that'll be nice, kind of expanding our geographic scope of participants in the collaborative as they're up in Traverse City. And then all 3 locations of the Michigan Kidney Consultants in Troy, Pontiac, and Southfield will be part of the collaborative as well. And it's going to represent 18 new nephrologists participating across these 4 sites. And with that, I will hand it back over to you, Dr. Hung. Though before we move on, does anyone have any questions about the remaining requirements for this year or the ones that will launch on March 1st? Okay, we'll share more closer to those dates, of course, to get you a PDF of the new VBR requirements, and we'll send out this recording, like I mentioned, and the reminders on the self-reflection exercise too for those in the first year. All right, I'll hand it off to you, Dr. Hung.
Great. Thanks very much for those updates, Jackie. I'm going to go over the data now. We have presented some of this data before, or we presented data before at some of the spring meetings, but as you may recall, we've had some data limitations in terms of what we've been able to get. I'm pleased to report we've made significant progress, and hopefully that's been reflected in the reports that you've received for your specific practices. There are still a few limitations, which I want to talk about. First, just to remind people what the sample is that we're looking at. We're focused on patients with type 2 diabetes, and that is defined either by a diagnostic code, by A1C criteria, or by the prescription of diabetes medications. And in terms of attributions, how are we finding these to assigning these to your practices? The patients have to be seen by an MCIC nephrologist as part of MCT2D at least 2 times in the past 12 months. The limitations I alluded to, we're still working to get broader data, to get all claims data, which has always been the goal for this. At present, though, we still are restricted to patients with Blue Cross Blue Shield of Michigan, PPO, Medicare Advantage, and the Blue Care Network and BCN Medicare Advantage. One other specific caveat is that some employers will purchase health coverage, but then have separate medication coverage, which is obviously what we're looking at to know about SGLT2 and GLP-1 prescription. And so if they have these, what we call carve-outs, where the medication insurance is actually separate from the Blue Cross insurance, we won't have data for that. So that is another limitation right now, something that we're also trying to address potentially for the future. With those in mind, caveats in mind, I'm going to go through the data now. In terms of overall diabetes medicines, we're going to present data for both the collaborative-wide for the primary care and nephrology, as well as just the nephrology component, just to give some comparison. And so this is the proportion of patients that have received SGLT2s and or GLP-1s. And as you can see, for SGLT2, it's about 18% in the overall collaborative, including primary care. And actually, if it's SGLT2 or GLP-1, that gets up to 43%, which is pretty good. In nephrology, we're a little bit behind with that, probably in part because we have patients with more advanced kidney disease that may not qualify for SGLT2s. And so we're at a little bit lower percentage there for SGLT2, also much lower for GLP-1, and about half of what we're seeing across the board for SGLT2 or GLP-1. And in both cases, a relatively small proportion of the group are on both. And by the way, please jump in with questions anytime, any clarifications that you guys might have. This shows the trend in the 2.5 years since we started this collaborative. It's been nice to see a positive trajectory in this. This is once again on the left, showing the overall MCT2D patient population, so including both primary care practices and the nephrology practices. And you can see for both the SGLT2 in the orange and the GLP-1s in the blue, that there's been a fairly steady rise, getting to the current levels that I just presented on the previous slide. And if we focus just on the nephrology practices, we also see a nice trend upwards for that. And hopefully we continue to see a nice upward trend for that. But that's certainly a significant improvement, basically nearly triple for SGLT2s in the previous 2.5, 3 years. So going to more specific lab breakdown, some of the lab values that we have available at this point, the hemoglobin A1C, again, comparison with the overall MCT2D collaborative, including primary care practices versus just nephrology. Not a whole lot of difference between there, maybe slightly higher in the nephrology practice group. And this breaks it down by the individual practices. So this is obviously de-identified, but you hopefully will receive the information to know which nephrology practice you are from this list. But again, you can there's not a lot of difference necessarily between the different practices in terms of the average A1Cs. Moving on to BMI, our population is on average obese, slightly lower in the nephrology group than in the overall larger group with PCPs. And again, not necessarily very big differences between the different practices within the nephrology component of MCT2D. In terms of eGFR, we are still working on this data in particular. The clinical lab data is reported in a different way than we get the claims data, and it is reliant on reporting from the practices and from the PO through various data channels. So you'll notice that we have fewer data points for these, even though we know that every one of our patients has, is going to have a creatinine and an eGFR. So that's something we're also working on the data end. But not surprisingly, with the data we have, the nephrology practices, of course, have a significantly lower average GFR compared to the overall primary care population. And not a whole lot of differences. As I said, for this practice where there's only 4 data points, again, that is a data reporting issue that we're working on, encouraging the practices to report the POs to report the eGFR. So in the future, we hope to significantly augment this and have more robust data to report. But within those limitations, again, not a huge difference across the different practices. Albuminuria, again, not surprisingly, a little bit higher a lot higher in the nephrology groups compared to the primary care population. And once again, it's kind of interesting. When I first looked at this, I was surprised that we seemed to have more data even for albuminuria than creatinine, when we know it's usually the opposite. And again, the albuminuria reporting is greater because it has become a HEDIS measure, and so that gets reported more routinely, and we're able to access that data. So these data points don't reflect how much testing you're actually doing. This unfortunately right now reflects the data that we're able to get. So we're working on that. And we do see some ranges in terms of the degree of albuminuria between practices. I think that's in part because some of the smaller sample sizes, and but if you look at the medians, they're not too far off. So these might be also affected by outliers. This is a breakdown of the relative proportions of patients in different eGFR stages. So once again, for the primary care practices, not surprisingly, the large majority are patients with fairly intact GFR ranges. This is just by GFR, not accounting for albuminuria, whereas it's a little bit more spread out with more significant chronic kidney disease in patients in the nephrology practices. When you look at the medication prescribing compared to eGFR stage, so in the primary care group here, SGLT2 versus GLP-1s, it's interesting, the majority here are actually in stage 1 and 2 for the primary care. And not surprisingly, maybe a lot lower once you get into stage 4 GFR. Similar relationship with the GLP-1s. And with nephrology practices, we're probably seeing more patients here, but in the stage 3 group is where a little over 60% of our patients are getting, of the patients that we have on SGLT2 inhibitors are in the stage 3 group. As opposed to the earlier stages like we see with primary care. And it's similar for the GLP-1s. This is a breakdown of by albuminuria stages, the A1, A2, and A3. And with the primary care group, the vast majority are in A1. In nephrology groups, it's still a majority in A1, but again, not surprisingly, we tend to see a little bit more of the patients with overt albuminuria. And breaking down the prescription by the albuminuria stages, in the primary care, once again, the vast majority are in the early stage, which again reflects their patient population, whereas we have greater prescription with the later stages of albuminuria or more overt albuminuria. And this is just let me see if I can move this. This is just a breakdown for the heat map, the CKD heat map that shows the overall breakdown of patients in the collaborative where they're following on the heat map. And this is obviously limited to those where we actually have available both GFR and albuminuria data. And you can see a large majority of patients are actually in these early stages. So those are clearly patients that we're probably not seeing as nephrology, but I think it's really quite interesting. Sometimes it's skewed, and I feel like every patient is down here, but that's the population I tend to see. But this actually gives me a lot of hope, because hopefully we can keep these patients here and not progressing down this heat map. Nonetheless, there's still a lot of opportunity here. And then this next slide is basically the same breakdown, but for nephrology practices. So again, not surprisingly, those thousands of patients that fall in the low risk category, we're not seeing. What's interesting to me that even in the high risk category, if I'm going to go back to the previous slide, you see higher numbers here, and we're capturing some of those, but not all of those. So I think that tells us that there are probably opportunities. There are patients still in the higher risk groups that have not been referred or not being followed by nephrology right now. So there might be some opportunity out there as well. So those are the data slides. I'm going to pause there for a sec, see if anybody has any questions or comments or any clarifications they want to ask about. Okay. I will keep on going then. Actually, I think we're gonna pause here, and I'm gonna let Jake walk us through the dashboard.
Yes, great. Thanks, Dr. Hung. Good evening, everyone. My name is Jake Reese. I'm the Associate Program Manager for the Michigan Collaborative for Type 2 Diabetes and the Michigan Collaborative for Kidney Improvement. So what I wanted to first start with before getting to the actual dashboard is how to access the dashboard, the first step. So on the MCTTD website, if you navigate to the top right-hand corner, you'll see this button titled Patient Data Dashboard. So if you click that button, that's what's going to take you over to the patient.
Are you sharing your screen?
I did. Did it not come through?
No, I don't see it.
Oh, it didn't come through. I'm sorry. Did it come through this time? It showed that I was.
Yep, there you go.
We can see it now.
Okay. All right. So let me say that again. If you navigate to the mcttd.org website, you're able to see in the top right-hand corner the patient data dashboard button. So if you click that, that'll take you over to this page here. So before you after you log in, it'll prompt you to log in with your Michigan Medicine Level 1 account information. So if you do not have that, I will talk about how you get access in a moment. After you log in, this is the page that you'll be brought to. This is just a standard attestation as to that you'll use the data properly and that it contains PHI and all that. Before going into this, just keep in mind, this is a demo environment. This is all fake data. So there's going to be a couple of things that probably won't make sense, and that's okay. This is not real data. And so there are two main sides to the dashboard right now. There is what we call the patient identification tool in the summary measures tab. So nephrologist attribution is built into the patient identification tool so far, and it is in progress for the summary measures tab, and that will be forthcoming with the refresh of the dashboard in early 2024. And so right now, what you're able to do as a nephrologist is utilize two tabs here. And this is, like I said, the patient identification component of the dashboard. And so the idea here is to give you as a provider the ability to look for patients that meet specific criteria of interest to you. So obviously in the medical record system that you have at your offices, you're able to search for patients by their name, date of birth, and MRN numbers. And some of you may have abilities to do larger population searches through like crystal reports or things like that, but not everybody and not every EMR has that ability, and even when they do, it can be kind of cumbersome. And so the idea behind this is to give you the ability to search for populations of interest based off of clinical metrics. And so there are two tabs here. As you can see on the top, it's very similar to a Google Chrome window that you have multiple tabs on. So the first one here is the patient list. These, and then right next to it is renal details. These two tabs function almost identically. The only difference behind them is the filters that are available on them. So the patient list was the original one. This includes many more metrics specific to diabetes. So it includes a multitude of different diabetes medication classes, and retinopathy screen status, ACE/ARB statin statuses, stuff like that. You have access to this, and nephrology attribution is built into this. But for the purpose of the demo, we're going to go over to the renal details tab for today. You'll notice that when I click over here, it's going to look very, very similar. It's going to function exactly the same. Like I say, the only difference is that there's going to be slightly different filters. And you're probably thinking, why didn't we just put all one filters on the same tab? Really, that's a technical limitation of Tableau, and the ability to have the number of rows worth of filters. The more filters you have on one tab, the slower it functions. And you'll notice as we go, it's not exactly the fastest, zippiest thing already. And so that was really the rationale behind that. There are still a number of diabetes specific metrics on the kidney specific, on the renal details tab. So through feedback sessions, we've tried to really get down to the ones that are most important for comparison along with those renal details. And so you'll see here that we still have whether or not they have a diagnosis of type 2 diabetes. Now, the question you're probably asking yourself is why I thought all these patients have diabetes. Yes, so the reason there is this filter is because there's actually 3 criteria that bring a patient into this list, and that's really important to understand. The first, obviously, is a documented diagnosis of type 2 diabetes. However, we know that with data flow through MyHIN all the way to MDC back to the dashboards, sometimes diagnoses are not always robustly reported through the data. Not that they're not on the chart, but just that data doesn't flow through. And so we wanted to make sure we catch patients that may not have that documentation of a diagnosis. And so the second one is an A1C greater than or equal to 6.5. Okay, and then the third would be on an antihypoglycemic medication, with the caveat that it explicitly excludes patients with type 1 diabetes. And so we're bringing in a larger net. So you may have some false positive patients, like for example, you may have a patient that's on metformin for PCOS or something like that, that makes it into this dashboard, but we wanted to cast a larger net and have an error on the side of inclusivity than error on the side of exclusivity. And so if you want to narrow this to just patients that have a diagnosis of type 2 diabetes, that's what that filter is for. And so one of the things that we can do today is we'll do a test case or a test filter. And I apologize in advance. I'm not a clinician, so maybe I don't do the best filter here, but let's say we want to find patients that have chronic kidney disease and type 2 diabetes who are not on an SGLT2 inhibitor. That could be a good candidate to get on an SGLT2 inhibitor. And so I'm going to unselect all here for type 2 diagnosis. I could leave this blank and just search for patients that have CKD and an elevated A1C or something like that. But we'll do yes here. And I hope that the criteria I use doesn't exclude everyone, because again, this is the test environment. We're going to say that they have to have chronic kidney disease. You'll notice that nothing's changing here. We're always going to have to click this apply button before anything updates. I'm going to search for patients that are not currently on, oops, this is not fun. This is, again, demo environment. This is an interesting catch. There should be an option for active here. I don't know. This is the demo environment and it's not upkept as well. So we're gonna change this a little bit. We're gonna pretend that we're looking for, why do none of these have filters? Okay, we're gonna have to use a real environment. Jackie, we have multiple POs on this call, correct? You're muted.
Yes, we do. We could use
Okay.
EMs if you wanted.
I'm gonna see if we can do it off the patient list, see if this one doesn't have the same issue. Let's see. This has the same issue. Where did this go on the demo environment? This was here literally last week. I'm so sorry, everybody. Okay, I'm gonna kind of walk through this as if this is how it would function because I can't show PHI for a different PO to other POs for obvious reasons. And so ideally there'll be a drop down here. It'll have all inactive or no RX and it'll have active. And so what we would want to do in this scenario is uncheck the active. And so I guess we can keep inactive or no RX selected here, and that'll work. It just won't, we can't do the inverse search. And so I'm going to go ahead and click apply. And so this should now show us all patients that have a diagnosis of type 2 diabetes, have chronic kidney disease, and do not, again, inactive, have an SGLT2 inhibitor. And so you can see that that knocked this list down from 1,300 something to 642. And so obviously this is still a lot of patients. This is still a lot of patients that don't have an SGLT2 inhibitor and can be a large list to work from. So we can do some additional filtering and knock it down even more. So let's get back to that 600 number. But we could also add in an A1C criteria. So let's say we want to start with patients that are not well controlled. So we could put in an A1C of something like 8.5, and then we could click apply, and that'll narrow our list down to only patients that both we have an A1C for, there's not always a documented A1C, and whose A1C is over 8.5. You can see now this has knocked down this list of patients down to 101. And so this one got reset as well. So we'll go back to the chronic kidney disease and the type 2 diabetes. And so now we're down to a list of, let's see what our magic number is here. 53 patients, a lot more manageable patient list that we can use to identify patients that may be good candidates for additional therapies or changes in therapies. We also have filters here for EGFR. You both have the ability to filter by the actual numeric value of the EGFR, as well as whether or not that is current, meaning that it has been taken within the last 12 months. You can search for patients that are not current and have a list of the patients that maybe you want to get an EGFR for, and same for albumin creatinine ratio. This pharmacy coverage filter here is calling out whether or not a patient has Blue Cross Blue Shield insurance. And so this is the carve out filter that Dr. Hung was talking about. And so like say, we only have medications data on patients that have pharmacy coverage through Blue Cross, meaning they do not have a carve out. So yes, they have pharmacy coverage through Blue Cross Blue Shield. And so this is a filter so that you could identify only those patients and make it even narrower. For ACE-ARBA status here, it'll be the same filter, and obviously, again, we're missing the active button here, not sure why. So this is the patient identification tool. This is what nephrologists have access to at this time. I am going to briefly show the summary measures tab. But before we do, I want to show that you have the ability to download this list. So it's not just available in here. So there's this button on the bottom right-hand corner. It's not the most obvious looking button, but you can see a box with an arrow pointing down, symbolizing download. And there's a number of different ways that you can select to download the data. If you want to download the list of patients, which is going to be the primary thing you want to download, you're going to want to click the crosstab button. That's going to pop up a dialog box here, and you're going to want to make sure that you select the renal patients, the list here, and then you can choose the format that you want to download it in, the Excel or CSV, which will function relatively similarly. And you can click download, and it'll download this list of filtered patients, this 53 patients, in an Excel file that you can then utilize with your clinic, rather than having to keep referencing the patient list in the dashboard. You are able to get a couple of additional details on individual patients by hovering over this magnifying glass. This magnifying glass will show you some additional info on that patient that isn't available by looking at these columns. You can also click on the patients and bring up a patient profile. It's going to be obviously very, very pared down compared to what you would find in your medical record system, but it can give you a little bit more information at a glance rather than having to go and look at every patient that you've identified or want to find out a little bit more on in your medical record system in your EMR. You can see the demographic information at the top and then the trends on the left for BMI, A1C, and weight. If you hover over these data points, it will tell you the dates that these were from as well. In the middle here, you have some biomarker and some medical history in the middle section. So you can see that this diagnosis, because we filtered for CKD, was last documented on 12/11/21. And then this patient does not have pharmacy coverage through Blue Shield of Michigan. So you're not seeing any pharmacy data here. I'm going to go back and show you what this looks like if you do have a patient that does have medications on file or does not have a carve out. But I'm not able to filter for specific ones, so we're going to try to find it. Okay. Right. The medications will show up here, a list of medications if they have pharmacy coverage through here. All right, very briefly, we're going to switch over to the summary measures tab here and show you what this looks like and what you'll have access to once nephrology attribution is added in early 2024 over here. And so this is really more of a traditional quality improvement dashboard that you're probably a little bit more used to seeing. And so the most important navigation feature is this left-hand column. And so the first thing you want to do is to select your organization, whatever it is that you are representing. And so we're going to choose this fictional PO Epsilon, and then we're going to select a comparator organization. It's going to default to the collaborative, and that's what we'll just leave it on for today. But if you're, for example, working at a PO and want to look at two different practices within your PO, that's how you would do that. Or if you wanted to look at your PO compared to the region that your PO falls into, that's available here as well. You can also, if you're at a practice, have one physician versus another versus the practice, or in a number of different comparisons like that. After you've selected your organization and your comparator organization, you have a choice of measures. And so these are all of the things that we've really been talking about in this collaborative since the beginning. And so what we'll look at here is we're currently defaulted to SGLT2 or GLP. So I'm going to select RX all, and we're going to focus on SGLT2s for this. But you'll see that we have a whole slew of medications as soon as this loads that pop up here. And this is really, really busy. It's hard to view. It's even worse when we do some different trend comparisons here. So we have this additional box that popped up once I clicked on RX all here. And we can do an RX drill down to really focus on only one specific medication. So like say, I'm going to click on SGLT2 here, and then you'll notice that the rest of them fade away. And we're able to just look at the PO Epsilon's rate of patients on an SGLT2 inhibitor versus the collaborative. One thing that I want to make sure is clear is you can always see these two color-coded notes on the bottom. And so whatever you select as your organization will always appear in this teal. You can, if you ever forget, you can always hover over anything. Always when in doubt, hover over things. It'll likely pop up with a tooltip. So we have the PO in teal and our comparison organization, the collaborative in navy. And so we have here 55.83% of patients do not have pharmacy coverage in the last month of the reporting period. So meaning that that's just calling out that this is not all patients we're receiving data on, but that a good chunk of them don't have data, so they're not included in this, obviously. And so we're able to look at this data in a couple of different ways. This is the bar graph view here. We also have the comparison trend here, and this is going to pull in additional items related to PO Epsilon. And so we want to take a peek and see how we compare to other practices within our PO or the region that the PO falls into. And so you can see we still have that color coding here, and then it pulled in gray the other comparator organizations. And then real quick, and Dr. Hung, I think I'm running a little low on time, if that's correct, is the trends view here. And so this is going to show how the PO has performed on this measure over time. This is going to be more of a traditional quality improvement run chart. And so you can see this is kind of close together, so it's a little hard, but again, hover over, you can see your numerator and your denominator and the total percents here. So you can see the color coding stayed the same, but you can see our date on the x-axis here over time. And this is actually going to be a longer 18-month phase in the actual live environment. Dr. Hunt, I'm going to pause there and ask how we're doing on time and if there's any questions.
Yeah.
Okay, what time do we have until for this?
Technically, we have this meeting until 7:30, so you have as much time as you need.
Okay. Okay, great. So this is the more traditional quality improvement, like I said, side of the dashboard. So these are all of the different elements or measures that we have currently available to look at. So like I said, the RX all is where you're going to go if you want to look at all of the different diabetes medications or drill down to one specific one. SGLT2 or GLP is really just meant to be this conglomerate measure that allows for you to look at them, all of these two medications. So really and or type thing. Is the patient on either of them or both of them? It's going to be included in that because it's one of, as we know, the more efficacious type 2 diabetes medications. This will always have these three options. These three options may slightly vary based on the measure that you've selected. And so the other one that we could look at that's highly relevant, obviously, for you folks is the statin status measure. And so if we look at this, we'll see that this is going to function almost identically to how we looked at the SGLT2 measure. So we can hover over it and these are going to stay the same as well. We can also click on our trends and comparators here. We can see that this fictional PO epsilon has 47% of their patients versus 50% in the collaborative on statin. One of the things that you can do is actually click on anything like this and it'll pop up the patients that make up that data point. And so this is a shortcut to finding those patients that may be on whatever it is that you filtered the measure to. And so you can see all of these patients now are available in this pop-up column here, and you can scroll through them and you can see measure on statin, patient result, yes. And so you can actually click on each one of these here and it will take you right back to that patient profile that we looked at, that we navigated to through the renal details tab as well. A lot of the features at the dashboard are multifunctional. So you'll notice yourself maybe clicking on things that you didn't realize you clicked on and it pops you to a different place. As you play around, you'll get more comfortable with what has additional features and functionalities and where the shortcuts are. There's lots and lots of bridges, what we call bridges, where one thing links to another thing and allows you to be able to navigate to, like I said, the denominator or the numerators that make up a specific data point. I know that A1C is not always the super most relevant measure, but I want to pull up A1C because I want to show that there are a few different ways that things differ in how they're displayed. So A1C is one of those items. Excuse me. And so we can see here that A1C is displayed on the default view, on that bar graph view, by buckets. And so we can see this is showing % of patients that fall into each one of these buckets. So of the patients within the collaborative that we have an A1C for at the PO and within the collaborative as a whole, there is 15.5% that are under 5.7 and 15.1% under 5.7 for the collaborative. Same for these other three buckets. And again, you can always hover over the bars and click on it. So if we wanted to say, let me see what patients are still above 9 in my collaborative, I can click on that 8.5% bar. And again, we're going to get this pop-up list and it'll show the value in real time on the list here. So you can have that as a quick and easy view for yourself. But what I really wanted to show with pulling up A1C here is how the different views have changed. You can see we have a number of additional options for views here now. And so we still have bar graph comparison and trend. Those are going to be the same as what we looked at before. But we now have this line graph option. And this is going to be a histogram-based view, a connected histogram. The bin size can be really confusing. And so I wanted to make sure to call this out. Bin size is saying what it's going to do is it's going to create a histogram or like a bell curve. And it's the bin size is what size or what from what A1C to what A1C is it saying a % of patients in. So if we have a bin size of 0.1%, it's going to give a data point or a % of patients in each 0.1% A1C. So it's going to say what % of patients have an A1C between 6.5 and 6.6 if we have a bin size of 0.1. If we have a bin size of 0.5, it would then give us what percent of patients have an A1C between 6.5 and 7, and then same for 1. And so we'll click on the bin size of 0.1 first. And this is really just to give you the ability to filter by different buckets of patients and drill down to a level that's most useful to you as the provider at your practice. And so this is what the histogram looks like. It's a connected histogram. And so as with everything, you can hover over any of these data points to see a little bit more detail on each one. As to be expected, we're showing a bell curve here with A1Cs averaging right around that 7 mark. And you can compare, obviously there's going to be a lot more noise or skewness in the PO because we're dealing with smaller N values, obviously, than the collaborative as a whole. So you can see that the collaborative values are a little bit smoother of a line. You can see that if we switch this to a bin size of 0.5, it's going to look like you would expect it to look. It's going to be a little bit more choppy. But you'd be able to hover over data points a little bit easier and see those buckets as it would relate to a smaller bin, or a larger bin, excuse me. And so we can then hover over and see, again, like I mentioned, that subset of patients that is from 6 to 6.49, whereas the next data point is going to be 6.5 to 6.99. You can see that in the top line there. So these are the different views and the ways that you can view things. I'm going to take a pause. I know that I've been talking at you for a while now, and there's a lot of information and a lot of different technical components to this. Are there any questions that I can answer for anybody? I do apologize for the technical difficulties with the demo environment on the patient identification tool.
Sorry if I missed you saying it. How often is the data refreshed or updated?
Sure, the data is updated and refreshed every 6 weeks. We release enhancements or additional features every 3 months. So 12 weeks versus 24 weeks.
All right, thanks.
Or 6 weeks versus 12 weeks, excuse me. Yeah. On the real environment, there'll always be, let me pull up what it looks like. I'm going to go back to the patient list tab. There'll be this banner here at the top, and it looks just like this in the real environment. That'll tell you, and this is actually correct as to the real data as well, what the data goes through. And so currently our data goes through August 31st of this year. And you can see here that it's different based off of claims and clinical data for the beginning date. So claims goes back to 2018 and clinical data being the TPQC data goes back to 2020. But the end date is the same. Other questions? Okay. Dr. Hung, I can either stop here or I can go through custom patient groups, whatever you would prefer.
Why don't you go ahead and introduce the custom patient groups?
Okay.
Yeah.
Okay, so this is something that you do have access to and ability to do. So on the patient identification tool, if I go back to the renal tab here, like I mentioned, you can click on each one of these patients to view their patient profile. So in addition to doing a filter and then being able to download that filter like we talked about, or the list from that filter, you also have the ability to build custom patient groups and add a patient to a list for being able to come back and view in the future. And so if I click into one of these patients, and again, I don't know what data is contained in all of them, but we have this big brown grayish bar that does not look like a button, but it actually is a button. Right now it says in follow-up patient list, no. And so if you want, you can click into these patients and add them to a follow-up list so that when you revisit the dashboard, you don't have to go through that filtering again to find that one specific patient that you were looking at previously. And so I'm going to go ahead and click this button, and you're going to notice that this is going to turn green and say yes. And so now this patient is in a custom patient group. Where is that custom patient group? So that's what this tab is here. And so what you have to do is click over to here and you'll see that this patient is now here, but we have to save this. We need to make sure that we save this list. And the reason you have to save it is because obviously there's only one list here. We want to make sure that you have the ability to have more than one list of patients. If you had to add every patient to the same list, that wouldn't necessarily be as useful. So you can see this button on the bottom right here that says View Original. In order to save this list, you're going to click on this button and it says Save Custom View. And so we're going to say F list 1123. And then you go ahead and click Save. And that's going to save this now under this list of views after it loads. And so you can see here now, when I go back to my custom patient groups, if I were to log off of the dashboard and then log back in, if I click over to custom patient groups, I go to view, and then it's going to show all of the custom lists that I've created here under my views. And so I can click between them. So I can go to custom list from February 2023 and see the patient that I added to that list. You can title them whatever it is that that search was for, and save them so that you can come back and check them out at a later date. That's how you're able to save them and not have to refilter to try and find that same patient again. So this looks. Seems to be tired. That's really it, though, with the patient list. That's how you're able to save those patients. So I will ask just one final time if there's any questions, and then Dr. Hung, I'll turn it back over to you.
Thanks very much, Jake. I just wanted to make a couple comments and follow up on that. First of all, hopefully Jake's demo makes it even more easy to understand how to go through this if you haven't already tried to play around with it. At least he's pointed out to where the key tabs are. I think it's actually fairly self-explanatory once you get in there and play with the different filters. And I think the clinicians can hopefully imagine how that would be very helpful. We've talked before in previous meetings about opportunity lists, meaning the patients that aren't yet on the therapies or don't yet have the testing that we want. And this is a pretty easy way to identify them. You might have noticed that one of the filters is by provider. So you can look it up by your own personal patient list, as well as in the practice. You can separate it out. For example, in this next section, I'm going to talk about some of the newer medicines, and you can look at for patients with a very high BMI. You could filter on that and say, oh, you know what, this patient might be better off for a GLP-1 in terms of an SGLT2. So I think there's a lot of different ways that you could think about using that. And moving forward with that. So I encourage all of you to take the chance to log in and play around with that, see how it's helpful. Some of you I know already have some kind of managed care type systems. I know, for example, one of the practices here at least works with Evergreen. So hopefully you're familiar with some of the different ways that they can help you manage it. And this is a free and relatively easy way to look at your own practice's data and do some of that yourself, especially if you're not part of one of those don't have those management companies working with your practice. And the last thing I'll say about that is also we are very open to feedback, and we're also available to help. So you will have a recording of this so you can play back Jake. Normally when I play back stuff, I play back in 2x speed, but with Jake, I might play it back in half speed because he's so fast with it. But
that was me talking slowly, Doctor.
So maybe normal speed for Jake. You can play it back, but so you'll be able to see some of those buttons. I think are less intuitive, as he pointed out, so it could be easy to forget. But we're also available to help out, to get on a call, walk you through it if need be, anytime, to show you more of the functionality. In that scenario, obviously, we can get on with you and go into your data and maybe do real-time tutoring on how to use that, and not just in the practice environment. And again, so we can help with that. And please feel free to give us feedback on what else you would like to see, what other capability you'd like to see.
Yeah, I was going to put this in the chat, but just to echo what Dr. Hung said, one of my favorite parts of my job is doing one-on-one sessions with folks and walking through data on it. So please don't hesitate to reach out if you'd like to meet. I would absolutely love to do a quick call with you.
Great. Any other comments on the dashboard? Okay, gonna move on to the next section. I thought it would be helpful to just take a step back and talk about some advances in chronic kidney disease management that are relevant to the collaborative. We've obviously previously spent a lot of time talking about the role of SGLT2s and their benefits and the GLP-1s. We have focused on things that are directly relevant to the collaborative, but many of you have asked in the past about, oh, what are you doing about finerenone or other things like that? So thought we'd give an update today on, and also what about non-diabetic kidney disease? So those are some of the things I'm going to talk about in the next little bit. Once again, please jump in with any comments or questions as we go. So no relevant disclosures from me. I'm going to, again, talk about recent literature that has expanded the indications for SGLT2 to patients with CKD without diabetes. I'm going to talk about the indications for the new non-selective MRA finerenone, and then go back to talking a little bit about GLP-1s and some emerging data there. So hopefully you all feel the same way as I do, which is that it's a pretty exciting time to be a nephrologist because, you know, when I started practicing almost 20 years ago, you know, it was really about ACE, ARB, and those were the main therapeutics. And really over the last several years, as you know, we've had a lot of therapeutics for general CKD, emerging things for IgA, for lupus, PKD as well. So I think it's a pretty exciting time, but it also is a challenging time to try to keep up with everything. And all the changes that have come about. So I'm going to talk a little bit first about SGLT2 inhibitors. For diabetic kidney disease, it's kind of a good news, bad news kind of picture. The good news is that we have seen some improvements with decreasing proportion of patients with diabetes having or developing chronic kidney disease. But as you all know, the bad news is that it's still the most common cause of kidney failure in the US. About 44% of incident cases still, which was over 60,000 patients in 2021. But back to some good news, we've had a whole bunch of different newer medicines come along for diabetes, and most notably the SGLT2 inhibitors and the GLP-1s. So I'm not going to recap any of the data that really demonstrated the benefits of the SGLT2 inhibitors in diabetic kidney disease. I think we're very familiar with that at this point. But over the last few years, there's been more data showing that they're beneficial not just in diabetes. And so obviously our collaborative is focused on diabetes patients, but I think it's all of us take care of non-diabetic CKD patients as well. So it's worth reviewing. This is the DAPA CKD study, over 4,000 patients. And again, their criteria was chronic kidney disease with or without diabetes. And they had about 1,400 patients that did not have diabetes. This was a high-risk group. The eGFR was in the 25 to 75 range, plus they had to have significant albuminuria. So this would be in the typically in the red, the high risk on the heat map. And most of them were already on ACE, ARBs, and statins. The primary outcome was a composite of renal relevant outcomes, 50% decrease in eGFR, development of ESRD, or death from renal or cardiovascular cause. And as you can see, it was significantly lower in the DAPA group compared to the placebo group, with the hazard ratio being 0.56. And the really interesting part, when they separated the subgroups into with or without diabetes, once again, the diabetes, we had seen that in a lot of the previous studies focused on diabetic patients with diabetic kidney disease. But even in the non-diabetic groups, significant benefits, arguably even more, with a hazard ratio of 0.5. So half the risk in the non-diabetic, which is pretty exciting to see. And then just earlier this year was published the EMPA kidney, so a similar study. This was a little bit larger, 6,600 patients. This was empagliflozin versus placebo. And again, more than half of the patients did not have diabetes. Similarly, CKD high risk with eGFR 20 to 45. or if they had a higher EGFR, they also had to have significant albuminuria. Similar primary outcome and similar findings with an overall statistically significant benefit with a hazard ratio of 0.72, so nearly 30% reduction in the risk of outcomes. What I'd like to point out at this study is, again, this added another 3,500 plus patients that did not have diabetes, and was still a statistically significant benefit in this group. This also included 2,300 patients with an EGFR less than 30. They recruited down to 20. And so that was a question early on with the SGLT2 inhibitors in terms of, should we be using this for GFR less than 30? The interesting part comes in the albuminuria group. So in the group that was basically normal albuminuric, there was not a statistically significant difference, as you can see here. Some people have commented on the data and basically showed that the slope of the GFR looked like it was better in the empagliflozin group, suggesting that if the patients were followed long enough, eventually those survival curves might separate. So that's not to say that for sure there's no benefit, but they weren't able to see it in the study period. Maybe simply because the patients were low enough risk, there weren't as many outcomes between the groups. And that's obviously speculation, but this is one of the areas that is less clear. So, this begs the question, should we be adding this to the water supply at this point with the SGLT2s? I think that there are clear outcome benefits in patients with diabetes who have known or are high risk for cardiovascular disease from a cardiovascular point of view, because we know it reduces cardiovascular risk. Similarly, there's the indication for heart failure. For the patients that we see and focusing on the outcomes of chronic kidney disease progression or kidney failure, I think it's pretty clear from the previous data that patients with diabetes and CKD and an EGFR of 20 can benefit from this. And we've now seen with the studies I just presented that patients without diabetes who have CKD, EGFR greater than 20, and albuminuria can also benefit from that. And that one area that's maybe a little bit less clear is non-diabetic CKD that doesn't have albuminuria. They may be so low risk that the benefit may not be as clear. But remember, they can also have cardiovascular benefits. So a lot of patients in this group will be at high cardiovascular risk and may still benefit from SGLT2s. These studies have led to a change in the labeling as well. So for dapagliflozin, the FDA did approve a new indication, which was CKD, not specifically diabetes. And they called it adults with chronic kidney disease at risk for progression. So they didn't specifically say that they have to have albuminuria, but the at risk for progression implies that maybe they have albuminuria. The same limitations as before. This is not for type 1 diabetes, has not been tested in PKD, and it's not for patients who have had immunosuppressive therapy for kidney disease recently. Empagliflozin, I've heard that the FDA is likely to provide this kind of indication, but that hasn't happened yet. But I am using these medicines more or less interchangeably for the non-diabetic CKD indication currently. And this is just, if you haven't noticed, these are new handouts. They've been updated and they are available at the mct2d.org page. We'll share these slides and you can click on this handout, but it's pretty easy to find under the resource library if you just put patient SGLT2 inhibitor. So they've just been redesigned a little bit. These are freely available for you to download and print out to share with your patients. As we've shared before, we have provider-facing handouts that are helpful to remind you of what side effects to talk about. I've taken to printing these out and handing this information page to the patient and talking over some of the side effects that they need to watch for, so they have something written that they can take with them to remind them about your education. I want to pause there and see if there's any feedback or comments about SGLT2s. Are most people are well on their way to using these in the non-diabetes population? Yeah, okay, you guys are all on the cutting edge. I see some nodding from Andrea and Brett and everything. So any challenges you guys have encountered?
Affordability is the biggest thing, especially for patients who, young patients who have jobs. They have a difficult time affording it. It's been my experience.
Affordability, same. The insurance don't approve it. Medications are expensive, and that is what the biggest challenge that I face.
Yeah, unfortunately, that remains a common refrain. I certainly see that as well. That's why this is a 2-page handout. The second page of the handout does provide some options for this in terms of being able to get a reduced copay or free medicine in some cases from the company. There's patient assistance. They can use the QR code to do that. We're lucky at Michigan Medicine. We have somebody to help with prior authorizations and to make appeals and things like that. But the patients, many of them are quite resourceful. I've had patients figure things out using these kinds of forms or contacting the company and being able to get the medication. And I hope that help is on the way. I mean, MCT2D, certainly one of the things that we're doing is advocating with insurance companies to try to make these more available. Blue Cross certainly has made a lot of improvements over the last few years in terms of coverage and raising to a better tier for these medicines. But I believe dapagliflozin might be the first one to come off generic and possibly within a couple of years. At least I've heard rumors of that. I don't actually know the exact date of coming off patent. But remember, the SGLT2 inhibitors, the main benefits we've seen in the last 5 years, but they've actually been available since 2013. So I'm kind of hoping we're getting close to the age of generics for these. Okay, so I'm going to move on and talk about the MRAs. And again, this is not one of the metrics, of course, for our collaborative right now, but many of you have asked about this in the past, and the primary care has asked about this at some of the meetings. So I thought it would be a good idea to take a look at this. As background, there's actually for a long time, there's been recognition that aldosterone probably plays a significant role in promoting fibrosis and tissue damage. We see that in the cardiac remodeling after an MI, where most of us are familiar with the use of spironolactone, for example, after in heart failure to help reduce outcomes and improve cardiac remodeling. And we recognize that probably the same thing is true in the kidneys. And some older studies have shown that aldosterone antagonists like spironolactone and naplerenone have been shown to reduce albuminuria in some animal models in small clinical trials. But more recently, there have been larger clinical trials using a novel agent, finerenone, which is a more selective non-steroidal mineralocorticoid receptor antagonist. And this study was, the Fidelio study was finerenone versus placebo, patients with diabetes, with CKD, significant CKD with albuminuria or higher EGFR with more albuminuria. Once again, like with the SGLT2 inhibitor trials, most patients were on ACE or ARB as part of the entry criteria, and patients had to have a K of less than 4.8. Primary outcome was 40% decrease in EGFR, kidney failure, or death from renal causes. And this was significantly lower in the finerenone versus placebo groups. Hazard ratio here is 0.8. And always important to know about the safety outcomes with a medicine like this, because again, they were already on RAS blockade, and so there's increased risk of hyperkalemia. And they did see that, and you can see here that the finerenone group on average had a higher potassium level throughout the study, but the degree of hyperkalemia actually leading to discontinuation was still higher in the finerenone group, but relatively low overall at 2.3%. And they did not see any deaths attributable to hyperkalemia or specifically in the study. They followed that up with another study, Figaro DKD, more patients, and the main purpose of this, they extended the criteria for this to higher levels of GFR, but with a higher risk as manifested as more significant albuminuria. Once again, a composite outcome, cardiovascular death, MI, cardiovascular disease, or CHF. This was actually more of a cardiovascular study, and they saw once again a significant reduction in cardiovascular outcomes. Secondary outcomes were a composite of kidney failure, decrease in EGFR, or renal death. And it didn't quite reach statistical significance with the composite, as you can see here, but everything was trending in that direction. Kidney failure was borderline significant, in fact. So seemed to be consistent, but the main benefit was in the overall cardiovascular benefits. And with this, as you probably have seen, this has actually led to a fairly quick approval. So this has been available since July of 2021, so a little over 2 years now, and fairly quickly adopted into guidelines. So the ADA's 2022 guideline recommended use of this in patients who are unable to use an SGLT2 inhibitors. And then the KDIGO guidelines suggested also non-steroidal MRA for patients with type 2 diabetes mellitus, and significant albuminuria if they were already on maximally tolerated RAS blockade. So just to give an idea of the different MRAs, spironolactone is one that's been available for decades that we're probably all familiar with. One of the key differences between the spironolactone, eplerenone, and finerenone, the steroidal versus non-steroidal, and the receptor selectivity. So this finerenone has higher receptor selectivity, which leads to lower or no side effects, such as the anti-androgenic, which can be pretty significant, especially with higher doses of spironolactone, such as the gynecomastia and such. Conversely, it doesn't have as much effect on blood pressure, so that can work for or against you for your patient. If your patient already has low blood pressure, it's an advantage because you won't further lower it significantly and make them lightheaded. But if your patient has refractory hypertension, I'm still using spironolactone in those cases as kind of a 2-for-1 to hopefully get better blood pressure control while hopefully decreasing their albuminuria. Of course, that's my speculation. In terms of clinical evidence, the studies I showed you with finerenone are the only trials that have been able to show this benefit in kidney outcomes. So there is still, and I don't think the trials will ever be done with spironolactone or eplerenone because there's not money to be made there, and I don't expect any head-to-head trials. And kind of like we just talked about with SGLT2 inhibitors, the newer medicine, finerenone, of course, is more expensive and a little bit more challenging to get to our patients. So I've encountered some of those issues. Although the company, I think it's Bayer, does have a pretty aggressive patient assistance program. So you may in your offices already have like coupon cards for finerenone already, because they've been really trying to make it more accessible for their patients. There are several unanswered questions with these still. These have only been tested in patients with diabetes so far, as I showed. There is an ongoing clinical trial for non-diabetic CKD that we probably won't hear about still for another couple years, though. A question that comes up a lot that I also have is, how do we use these in combination with SGLT2s? There is a study doing a comparison that's coming out. We may hear things as early as a year from now. At present, just in terms of the preponderance of evidence and the magnitude of benefit, even though it's not apples to apples comparison, I am still using SGLT2 inhibitors first, and then going to finerenone when either they're refractory or for whatever reason they can't take an SGLT2 inhibitor, which is consistent with the guidelines I showed earlier. And then, as I kind of alluded to, what are the benefits compared to some of the older MRAs like spironolactone and eplerenone? I've asked people this question, experts in the field, and it comes down to the evidence basis right now is proven for finerenone. It does seem to have a better side effect profile. I still think these medicines could be beneficial, and basically, if I can't use finerenone, then I am trying to use these medicines in its place. So again, let me pause there with the MRAs and see if anybody has any comments or thoughts about this. Again, one of the newer medicines that's become available to us. And also, I have to say their marketing must be very aggressive, because this is probably the one medicine I get asked about from patients the most, even more than SGLT2 inhibitors. I don't know if anybody else has had that experience, but they keep coming in and asking about Kerendia. So. Okay, I'm going to continue on the update then. And the third and last thing I'm going to talk about is some updates on the GLP-1 receptor agonists in diabetic kidney disease. First, a quick update. This you may have seen this in the news. The FLOW trial is a randomized control trial of semaglutide versus placebo in patients with type 2 diabetes and chronic kidney disease, where they were specifically looking at the kidney outcomes. So the trials to this point with the GLPs have really focused on cardiovascular outcomes, where we've seen benefit, but they haven't really been looking as closely for the kidney outcomes. So unlike the SGLT2 inhibitors, where there's been pretty well demonstrated benefit in reducing hard kidney outcomes, the evidence hasn't been as clear for the GLPs. That might be changing because basically a little over a month ago, it was revealed that the study was stopped early due to recommendations from their Data Safety Monitoring Board because the interim analysis met efficacy criteria. So it seems like this study is going to be a positive study showing reduction in this composite outcome. So that got a lot of buzz at ASN Kidney Week a couple of weeks ago. I have not seen any actual data on this. This was not presented at Kidney Week. I'm sure they're working on cleaning the data. I haven't heard if and when they might present the updated data. But again, kind of exciting that the GLPs may also have kidney benefits. And then I wanted to spend a little bit of time talking about tirzepatide, which is a newer medicine that some of you may be familiar with. You may have heard of it as the brand name is Mounjaro. This is a kind of a new class. It is a GLP-1 receptor agonist, but also a GIP agonist. And this was new to me. The GIP is a glucose-dependent insulinotropic polypeptide receptor. And it has similar roles to the GLP, but also complementary, decreases desire for food intake, does not lead to as much nausea, and helps with decreasing body weight, also works on insulin sensitivity, kind of much like the GLP-1 receptor. So it seems to have a pretty similar side effect profiles to the other established GLP-1 receptor agonists. In particular, it has been noted to have a very low risk of hypoglycemia, essentially no hypoglycemia when used on its own. The hypoglycemia is only seen when used with insulin or sulfonylurea. And I think the thing that's getting so much buzz with this medicine is so first of all, it's has similar, if not slightly better, glycemic control compared to dulaglutide and semaglutide, some of the other GLP-1s. But the thing I think that's gotten a lot of attention is it seems to have even more pronounced weight loss. This is not highlighted here, but 36% of patients achieved greater than 15% weight loss. And that's not even a category in some of the others. So most of the other GLPs have been shown in some patients to have up to 10%. And you're seeing even more remarkable weight loss outcomes with tirzepatide. In fact, I believe this was just approved for a weight loss indication under a different brand name, but it's the same medicine, the tirzepatide. So again, the clinical trial outcomes, there's more coming out. All the clinical trials to this point with tirzepatide have been focused on demonstrating the weight loss and the impact on glucose control. The actual outcome studies have not been published yet, but are underway. And so it's not clear whether this is going to have the same beneficial cardiovascular effects. We're waiting for official word on that, but hopefully that's the case. And I kind of alluded to this earlier, but in your super morbid obese patients, this might be a better first-line drug than and even an SGLT2 or the other GLP-1s, just because the benefits from the weight loss may be quite significant and have positive effects secondarily on the diabetes, on the blood pressure, cardiovascular disease, and thereby kidney disease. So just a newer med that I hadn't heard much about until maybe 6 months ago, but is very interesting because of its novel mechanism of action with the GIP receptor, as well as the really remarkable weight loss impact. So the summary, the three things we talked about, kind of updating that SGLT2 inhibitors have been demonstrated to be beneficial now in the non-diabetic chronic kidney disease group. The emerging role of finerenone as the first non-steroidal MRA to reduce cardiovascular risk and improve kidney outcomes, with more data to come. And as we just talked about, the emerging data with the GLP-1s. So again, let me pause there and see what if anybody has any thoughts on any of these areas, or any questions about the newer GLP-1 data.
Are there still a lot of shortages getting GLP-1s, Mike?
I'm not sure, actually. I know it's gotten better. I think there are still shortages, and the irony was that you could get I think because these are typically increased stepwise, you could get like the middle level at one point, but you couldn't get the first level. Jake, do you have an update on that?
Yeah, I was just going to say, we just got done doing our regional meetings, and from feedback from the primary care colleagues in the collaborative, they are still reporting quite significant shortages on the GLPs at this point. And so it does seem to continue to be a very prevalent issue.
It's because of all the Hollywood actors on them, right?
Well, yeah, I do think we have seen that there has been clampdown on the prescribing of these medications that are indicated for type 2 diabetes for weight loss alone. So ideally, hopefully that'll help with availability for patients that do have actual type 2 diabetes. And But however, the shortages of the obesity specific ones, the Saxenda and Wegovy, continue to be a real issue as well.
Thanks, Jake.
Mhm.
Any other questions or comments? Okay, we just wanted to kind of wrap up the meeting with a little bit of time. Hopefully we can get some good discussion here about the future directions for the nephrology component of MCT2D. As you know, we've focused so far on the metrics of SGLT2 and GLP-1s, as well as albuminuria testing. I think those are pretty straightforward metrics. We're still working on the data, as you've seen, and still want to provide support to individual practices to help out in any way we can. But I think it's also worth taking some time to think about what we might be interested in doing as a collaborative going forward in the future. So some potential ideas, and this is an open session at this point, could be, what different future measures people have in mind or might be interested in. Are there any other types of data that you would like to see? What kind of support does your practice need? And one area in particular is the role of the social determinants of health. We know of, I think we're all familiar with the disparities that we see in patients with kidney disease and the impact of socioeconomics and access to care and health literacy and other social determinants of health. So we're actually partnering with one of the other CQIs, M-Shield, that is, their main focus is on examining social determinants of health in patients in Michigan. And so we're working, that's a future direction that we're already thinking about, but any feedback on any of these areas would be great.
I will say for our practice, the handouts on the website are very nice. We print them out and hand them out to our patients. So any more resources like that for patients is helpful and useful. So
great, thanks. And Brett, you may or may not know, because you guys are relatively new, we actually have a whole design team. So I can't even take credit for these slides. The design team, I've gotten very spoiled. They help us put these nice things together, and they're available to help. So as you may have seen at the regional meetings, we had some design contests where we have posters that were based on input from the primary care practices. So if there are things that in particular that you're interested in, please let us know. Actually,
that's because we were talking about, is there a way, do you know, to like include those in Epic so you can just, instead of handing them out, because what we were talking about, see if there's like an Epic, I don't know what it'd be called, it wouldn't be a smart phrase, but they have those ambulatory handouts.
Mm-hmm.
If there's a way to do that, that'd even be more helpful, because then you could just do it with their after visit summary.
Yeah, no, there definitely is a way. I don't think it's a universal way is the issue. Like,
right.
Like it's not coming from Epic on down.
Right.
But basically, if you work with your IT department, which is what we had to do at Michigan Medicine, our IT will allow external resources like that to be put in, but there are some certain rules around that. I can't remember exactly all the rules around that, but we can say this is an externally vetted thing, and we were able to get it into our EHR.
Okay, so it is doable. I just have to find the right people to do it.
Yeah.
I think the other thing, Brett, this is Julie. How are you?
Good. How are you?
Good. So yeah, I mean, getting IT to sign off on it or whoever's in compliance, but I mean, before we got more, I guess, savvy about all the EMR things, and I was able to like cut and paste PDFs, quite frankly, into my own dot phrase and have done that. And, you know, not like I'm suggesting everybody go rogue and do that, but it can be pretty easily done. And that, as you know, any dot phrase can be put. Smart phrases and dot phrases I've learned are different. I don't know if that's true for everybody, but dot phrases, I mean, doctors can make those however they want here. Again, I'm sure there's some stipulations, but you can cut and paste PDFs into that. I'm just saying.
That's good to know.
And that's totally the kind of thing that we could help with as well. So if you had somebody in your practice that wanted, you know, it wasn't clear how to do this, wanted to reach out, we can tell you exactly what we did. We can try to walk you through it. We can provide documentation that it's an REHR that might be helpful to your IT. So again, please view us as that resource to help out.
Hi, this is Dr. Madawi. When in one of the meetings, you were talking about a library for dot phrases that can be shared. You remember? So
we do have that. I can find a link and put it in the chat for everyone.
Thanks, Jackie. Yeah, so again, if there are specific types of handouts, you know, this comes up for me every so often, you know, in clinic, trying to provide education for my patients. I do a lot of talking. I will send them to some websites that I think are pretty good, like the NKF. But it's you know, we have some NKF handouts in our office, but we don't always have the pamphlets. So it's occurred to me that, you know, for specific areas, you know, we have this resource through MCT2D to develop some of these materials. So if you're encountering the same thing and you have a great idea of how something should look, or just want to throw an idea out there for an educational handout on a specific area, please let us know. We'd love to work on that with you and put our resources to work for you.
On the note of the handouts, Mike, when they get updated, are there any like notices that go out? Because I handed out the old versions today. So maybe like reminders when they're updated or something like that would be great too, so that I can make sure we print out the new versions. I know the information is probably pretty similar.
Yeah, no, that's a great point. We can definitely work on that. I don't know that did we send out a specific notification of the update, Jackie?
To our website or of the tool?
To the practice champions, yeah, for the when we updated the patient facing handout. It was fairly recent, Andrea. It was within the past month or 6 weeks, I think. Yeah,
we didn't send out a specific notification that it was updated, no.
Okay. So we can work on that in the future. You're right, though. The it's more design than a little bit easier to read, less text heavy than the old one, but the material is basically the same. So you didn't hand out anything that was like terribly obsolete or anything. Any other thoughts on future directions that any of you would like to see the collaborative go in? So obviously, again, we've started out focused on type 2 diabetes and chronic kidney disease. Okay, as always, I hope you know, one of the things that our team always talks about as the coordinating center is how we want to make sure that each of you views this as a value-added proposition to be part of this collaborative. And I hope that each of you feels that way and also feels ownership over this. And we will have these types of discussions at every meeting because we want your input. to guide this going forward. This is owned by all of us, and we all have the shared goal of helping our patients in the state of Michigan. So thank you guys all for coming tonight. I think that's the last part of the agenda, right, Jackie? Is there anything else?
Yep, that's right. And I'm gonna have to email everyone the dot phrase library. I apologize. We'll send a follow-up to everyone on the call, though I'm unable to find the right link to it right now, but we'll make sure everyone gets that.
Yep. But thank you, everybody. And as always, please don't hesitate to reach out to any of us in the coordinating center, myself, Julie, Rajiv, Saran, Jackie, Jake. We're available to help out, whether it's supporting your practice directly, helping with helping with the dashboard, how to use it, or helping to develop handouts as we just talked about. So we'd love to help. Have a good night, everybody.
Thank you.
Thank
Have
you.
a good
Good
night.
night.
Thank you.
Thank you.